Hello and welcome to Healthy Living. I'm Dr. Donald Pelto and I'm here with Dr. Ray McClanahan. He is the inventor of Correctos and he's in private practice as a podiatrist, and Ray is an inspiration to the podiatry profession. So Ray, thank you for coming to the show. Welcome to the show via Skype.
Thank you so much for having me.
So we appreciate you taking your time. You're a couple of hours difference in terms of the time zone. So I'd like to ask you a little bit, how did you come out about with this idea of Correctos or these toe spacers, and kind of tell people a little bit what it's like?
You bet. When I was doing my podiatric residency out here in Portland, Oregon, I actually had a bunion on both of my feet. And for your audience members, I had what you and I in podiatry would call an overlapping toe with a bunion. So my second toe sat up on top of my big toe. And during residency, we were probably correcting, 8 or 10 bunions a week, I would say. And as a surgeon yourself, I'm sure you're familiar with cutting the adductor hallucis muscle off of the big toe and the sesamoid bone. And as an active athlete, I kind of cringed at the idea of having that operation myself. And so I got to thinking about bunions and foot deformities in terms of physical therapy type principles, in terms of maybe stretching the muscles. And that's kind of what got me interested in Correctos. But what really kind of pushed me over the edge was reading the work of Dr. William Rossi. In 1999, a Podiatry Management magazine came out with an article called "Why Shoes Make Normal Gait Impossible." And I was very interested in gait at that time, and I had a treadmill in the practice and was putting everybody on the treadmill and evaluating their gait. But what Dr. Rossi taught me, I didn't learn in podiatry school, and I'm not sure which school you went to. I went to Temple, but Dr. Rossi got me thinking about concepts that I didn't hear about in podiatry school. Concepts such as maybe some of the footwear that we're wearing in America is playing into some of these deformities that we get, which again is not something that I was taught at Temple. So I decided for my own foot, rather than to have bunionectomies, I was going to see if I could take a more slow, gradual approach. So I started buying these little single silicone spacers you can get these days at the pharmacy. You probably stock them in your practice. Most podiatrists do. I started putting them between my first and second toes, and I noticed that my big toe started getting straighter, and it started coming out from under my second toe. And then I started putting one between my fourth and fifth toes because, like most runners, my fifth toe was completely under my fourth toe. And I had no concept that the natural human foot is supposed to be widest at the tips of the toes. Even though I grew up in Liberia, West Africa, where most people over there still have a natural shaped foot, even in their fifth and sixth decade. And for your audience members, natural foot shape means to be widest at the tips of the toes. We see this in the baby foot, and we make baby shoes for that shape, but only for a few years. And then most of the footwear, even for athletics, which I do mostly sports medicine, so even the shoes for my walkers, hikers, runners, basketball players are widest at the ball of the foot. So once we started spreading out our toes, I started telling the patients about it. My feet started getting straighter. My knee pain started feeling better. The problem was there was no shoes available to do this work back then. So we literally wore Birkenstocks and Crocs. We did our marathons in Crocs, if you can believe that. We really did. I ran my very best marathon in a pair of Crocs. And what was different about it is I felt good enough to run the next day, which I had never done before after a marathon. And Dr. Feldman, who you work with, probably would tell you the next day after a 100-miler, he's probably not going out for a jog. But what I learned is there is a lot of value to spreading the toes back out to natural alignment. The problem was the single silicone spacers wouldn't stay in place. I'd go out running and my foot would sweat and it would start squishing out. So a designer buddy of mine and I got to talking, and we decided to put 4 of those pieces together and make the outer 2 cavities modifiable for people with bunions and people with bunionettes, so that we could take an approach that's more like orthodontics or more like dentistry, a very slow, gradual approach. You're probably familiar with this Invisalign product, that silicone product that you put in the palate. We're doing a similar kind of work with feet, slow, gradual process. The problem is it is slow. And the other problem is people have to wear a kind of shoe that most people have an aversion to wearing. Most of my female patients want to look pretty like every other woman in the world. And unfortunately, in our society and most other industrialized societies, we do truly have an aversion to the natural foot shape. We don't like the way it looks. We like pointed, pretty, tapered. And in my experience, I think that causes a lot of the problems that come into our offices eventually.
Now, what percentage of your patients do you find that you put into the Correctos product, and how I guess Are they willing to use it? Are they not willing to use it? Do they try it for a period and then give up? And then how long does it take to see if, for example, you see just a typical bunion? Does it reverse? Does it go away, or does it just kind of prevent it from getting worse?
Yeah, so probably I'd say 80 to 90% of our patients will wear correct toes. We don't put them on our diabetic patients with neuropathy. We're concerned about, certainly rubbing on the skin and so forth. So I'd say a majority of our patients will use it, because the majority of them, when we have them stand on the sock liners that come out of their footwear, 90% of them are wider than their sock liner. And so for your audience member, the sock liner is that little removable piece that you can take out of your shoe. So we're very interested in the majority of the patients getting back to that natural foot alignment. The bunions do reverse, including my own. We've got photographic testimonials on the website, and it happens as quickly as 30 minutes. The problem is that 30 minutes is not a permanent change.
Okay.
For instance, when the patient comes in, we spend an hour with every new patient. While we're talking about this, since it's brand new information, we will put a correct toes on one of their feet and just have it on their foot while we're visiting together. At the end of the visit, we'll take the correct toes off, and there will be a space between their toes, but only for a few minutes, because the muscles have learned that tapered anatomy. It's a long process, doctor. It takes several years for people to make a meaningful, lasting change, typically.
Okay.
And they have to be really faithful with the footwear, especially. But it happens almost immediately, but the permanent changes are long term.
Okay.
So this is why we call it lifestyle medicine. It's not to be thought of as what a bunionectomy would do, where we take the person to the hospital and by the next day their big toe is straight. This is more rehabbing the soft tissues around the joint, which, as you can imagine, are not going to happen within a few weeks to months. Mm-hmm. So we do have photographic evidence on the website. It works, but it's ungratifyingly slow. And the bigger obstacle, I think, for a lot of people is the footwear that's required to wear with it, which a lot of people don't like the look of that.
Yeah. For those that are watching, if they want to learn more about looking at the correct toes and also the types of shoes, I know you have a shoe reference guide as well. What's the website they should go to?
Yeah, we've got two websites. The best one probably would be correcttoes.com. We also have a clinical website, nwfootankle.com. And either one of those have all kinds of information about footwear fitting. We've got probably 90 videos on YouTube. So if people want to get a natural impression about how we would work up a bunion or a hammer toe or plantar fascial issues, they can certainly go on the website. They can go to YouTube and plug any of these entities in and learn a lot about us.
Perfect. And you've been in practice for how long? And then how long have you been utilizing the correct toes? And how has this changed, let's say, things that we looked at podiatrists, like your surgical numbers, your injections, things like that?
Yeah, I've been in practice for 26 years, and I've been doing this kind of work for about 20 of those 26. I have a very minimal surgical practice these days. I don't even do any of the big hospital-based cases anymore. I send those out. I do little stuff in the office, but overwhelmingly, I basically just educate people about footwear. And if we can talk them into getting their feet naturally aligned, I also make significantly less orthotics. I used to work for Superfeet, Northwest Podiatric Labs. Mm-hmm. And I used to make orthotics for a lot of people until I started cluing into the fact that our footwear oftentimes weakens our feet and our arches and requires the need to lift them up. I do still give, fair bit of injection therapy. I'll use cortisone. I'll use sclerotherapy for some neuromas and so forth. But overwhelmingly, I'm a very natural, non-traditional sports medicine podiatry practice.
And you consider yourself pretty successful at it. Like, patients are getting better. They're pleased with the results. If you can find the proper patient to try.
You bet. And one of the most gratifying things is when people do write testimonials about how they've done. Yeah. I think more than any research project, if you've got a happy patient, that speaks volumes. And
they're going to share that with other patients along the way. I want to talk a little bit about the kind of this difference between a good minimalistic shoe. Maybe we can talk a little bit about what zero drop is, what a wide mouth or a wide front of the foot, and also how this can strengthen and maybe not utilize orthotics. Because right now, for a lot of our patients that are very flat-footed, we'll put them in a very stable, one typical shoe is like a Brooks Beast or something like that. And you're kind of going totally the other way with this. So explain a little bit about that.
You bet. Once I read Dr. Rossi, he got me thinking about what elevated heel footwear does to our Achilles and our calf muscles. I've got a study on the website where they took two groups of ladies. One group was on a 2-inch heel, the other group was on a flat shoe. The 2-inch heel group was 13% shorter in their calf muscles. So I talked to the patients about getting into a flat or a zero drop shoe. We didn't even have the term zero drop when I read about Dr. Rossi. He just talked about a flat shoe.
Yeah.
And for him, what a flat shoe meant was we wouldn't have heel elevation and we wouldn't have a feature called toe spring. For the audience members, that's if you look at the shoe on the shoe wall, the front of the toe box will go upward.
Mm-hmm.
And essentially what that's doing is that's holding our toes above the support surface, displacing our fat pad distally, overstretching our plantar fascial ligament and our plantar intrinsic muscles. The third thing we talk about is a natural shaped toe box, which I try to be really careful not to use the term wide toe box because shoe industry people take that to mean widest at the ball of the foot and getting progressively wider.
Mm-hmm.
So we are very particular to ask our clients to look for shoes that are widest at the tips of their toes. And unfortunately for a lot of people, this is brand new information about what natural foot anatomy is because we change it so early in our lives that we look at each other's feet, our feet look like shoes, we don't think anything of it until people break down. So those are the three things. The other thing we talk about is torsional rigidity. In other words, even though the podiatric community embraces shoes like the Brooks Beast and shoes that are very stiff, I've scoured the literature, as have many of my clients, and I'm not coming up with statistics that make me feel really comfortable that that's going to be a long-term strategy for my patients.
Okay.
Other than if I want them just to feel better. In other words, if I want them to feel better, stiffening things up, partially immobilizing things, changing the biomechanics with an orthotic will oftentimes get them symptomatically better. But I found in that patient population, I'll oftentimes see them again and again and again. So really what I'm trying to do is I'm trying to get them to rely on their own anatomy. And in the patient that's able to do that, I'm trying to get them stronger. And I personally don't believe we can adequately strengthen our arch muscles if our heel is higher and the toes are up in the air.
Okay.
There's that length to tension relationship that you and I studied in muscle physiology. And when the heel is up and when the toes are up, the muscles are just too long to really do any good work. And so we try to bring them closer together. We really just try to mobilize the foot and strengthen it. And we do get really good results with our patient population.
Now, do you have physical therapy in your office? Do you give them exercises? Do you do short foot exercises and things like that? Or do you send it out or do you keep it in-house? How do you do that?
I do all of my lower extremity, I should say from the knee down, in-house. And every patient gets short foot. Every patient gets toe spreading. We pick up a lot of things with our toes. We give a hacky sack to all of our patients. We ask them when they're at their workstation just to be grabbing that hacky sack. So we do most of our lower extremity stuff in-house, but obviously I think you might agree with me that some of what we see isn't just related to the feet. And so I have great relationships with physical therapists, myofascial therapists, massage therapists, chiropractors, people who will look at the rest of the body in a detailed fashion that I'm not trained to do and I don't have time to do it. And quite frankly, as you know, we have a scope of practice too, that kind of mandates what we can do, what we can't do, but everybody gets strengthening.
Okay.
But I honestly have this impression that's recently been borne out in the literature that if our patients never did a single exercise but just started taking their shoes off a little bit more, started wearing some more natural footwear, there's at least 7 studies that I've reviewed, including a recent study, that our plantar intrinsic muscles will get about 10% stronger without any exercises.
Just by walking?
So in other words, the flatter, more flexible shoe will do some of that for us in a favorable way.
Now, you mentioned you're originally from West Africa, right?
Well, actually, I'm originally from Washington, but I did spend some time in Liberia.
Okay. And what's interesting there is when you're there and let's say you look at 100 people, how many of them have foot deformities? Is it something that they don't have compared to 100 patients here that you're looking at?
They have foot deformities, but they're not what we see. You and I are seeing the bunions and the hammer toes and the, bunionettes and so forth. They have leprosy. They have tuberculosis. They've got all kind of infectious diseases of their lower extremity. They do traumatize themselves too. They'll fall out of the coconut tree and break a bone. But as far as bunions, I didn't see a single bunion, didn't see a single hammer toe. No, literally, and this is what Dr. Rossi taught me, and this is what I think podiatrists should be exposed to, is the difference between what we see in those patient populations and what we see in industrialized societies like America, Canada, Europe, where we change the structure of our feet with our footwear over our lifetime. And the literature is full of documents pertaining to that. So I think podiatrists should be exposed to a little bit more of that. Same thing. I've been to Asia. I've been to South America. When you get out of the cities where they're not wearing the same kind of footwear that we wear, you see a different subset of foot problems, and most of them are not the cumulative musculoskeletal deformities that we see. They're infectious disease and traumatic.
Yeah. Now, I know for the ladies that are watching, they're probably thinking, I'm not going to wear these 100% of the time. They're ugly, things like that. What words do you give to the women that need to wear a dress shoe? Are there some minimal, I don't know what word you want to use, minimalistic dress shoes out there? Or do you wear open-toed sandals? What type of recommendations? Do you use like an 80-20 rule? That's where you wear 80% good shoes, 20% bad shoes. Is there some leeway for that?
Absolutely, there is. I see a different subset of patients. I see the older females that have been through a lot of maybe procedures and a lot of treatments, and all they want to do is walk or hike or go on nice vacations. They don't care what their shoes look like. They do this natural healing 100% of the time. I see them 1 or 2 times. I don't see them again. They're gone out of the practice. I also see people who work for companies where they either have a dress code and they have to dress up, or they feel like they need to dress up, and they come home at night and they spread their toes and they wear better shoes and they go barefoot. But I see them a lot more. I don't tell anybody never wear dress shoes. I tell all of my female patients to wear dress shoes from time to time and enjoy it. Church, the opera, nice theater, nice dinner. But what we've discovered here is once people spread their toes out, get their feet strong, they won't tolerate a lot of the fashion footwear that they previously wore. And we didn't know this would happen when we started this project, but nearly universally the female patients will come in and they'll say, yes, I'm feeling better, but I tried to put on my dance coat, or I tried to put on this shoe that I used to wear, and within 5 minutes their body is telling them, this hurts me and I don't want to wear that. We also do something that helps us, and it also helps guide patients away from our clinic that wouldn't be appropriate. We actually pre-screen patients. And one of our questions in the pre-screening is, are you willing to change your footwear? Because if they're not willing to change their footwear, all I can offer them is traditional podiatry. And I'm proud of traditional podiatry, and I'm proud of all the things I've learned to offer them. But I also would love to see the two of those melded together. I love to see education and natural principles employed even if we need to do treatment. And I think one of the downsides of our profession is oftentimes we don't do natural preventive healing things after some of our surgical interventions. We send people right back into the same footwear. So we do encourage people to dress up, but interestingly, their bodies will become hypersensitive to things that never used to bother them before. And we joke about it in the clinic. I tell them, my job's done, just listen to your body, but obviously it's not that simple. I tell the female patients the hardest thing in America for a woman is to look the way they're intended to look and have healthy feet. It's almost an impossibility in my opinion. But the other part of your question is, yes, we do have a shoe list, and we do have some more natural dress shoes. Again, for the average younger female, they're not going to appeal to her because they're going to be wider at the tips of the toes. And like we talked about a moment ago, most females are conditioned to like that slender, sleek, pointed taper. But I also firmly believe that is at least partly responsible for bringing a lot of people into our offices.
And now a lot of people, I think we're going to kind of go, well, let me ask you, any other things, any other tips that we can go, because I want to go a little bit into wearing correct toes on a daily basis. Do most people find shoes that are appropriate to wear when they get home? Do they keep them on? Do they take them off when they're barefoot? There's something called, I think it's Indigi socks, these socks that people use. Some tips for people that are trying to wear them. Does it work better with socks, without socks? Wear them at home, not at home? When do you take them off? Just when you shower and sleep, or are there other tips?
Yeah, for your audience members, I would encourage everybody to get some kind of a toe sock. We like in gingies, and just wearing a toe sock without a toe separator is an eye-opening experience for a lot of people. So we would highly recommend those. Um, we usually break in the Correct Toes product about 30 minutes the first evening at home, either in their bare feet or in their house slippers or in a regular sock, but even regular socks will squeeze our toes together just like a tight shoe will. So we'll have people stretch their socks, even if they're going to wear that kind of sock or wear a toe sock. But the break-in process is 30 minutes the first night, an hour the next day, hour and a half the next day. So we add a half an hour each additional day to where people can be comfortable wearing them all day in about 3 to 4 weeks. Our goal is for them to wear them in their footwear. We have people have done 100-mile races in them. In fact, a lot of our folks that are ultra runners have had much less blistering, much less skin breakdown, arch fatigue by getting the toes spread out like that. So definitely we love toe socks. We go slow. The Correct Toes has a money-back guarantee. If people want to try it and they don't like it, for 30 days they can try it. It's highly modifiable, so as you know, not everybody's feet are the same, and it doesn't fit everybody the same. We also are huge fans of metatarsal pads, and I know you probably use them some in your practice, and most podiatrists do, but when I understood what Dr. Rossi was teaching about the over-lengthening of the plantar intrinsic muscles and the plantar fascia, we find that the flat shoe plus a metatarsal pad is able to bring those plantar intrinsics and plantar fascia into a shortened position, which we find to be very effective. But most people will eventually get to the point where they don't even feel they've got it on. It's medical grade silicone, so it becomes soft when it gets next to warm toes.
Mm-hmm. In one pair of these, how long do they need? Multiple pairs? Is one pair enough? How long? Let's say you use it every single day. How long does it last? A couple of years?
Yeah, if they're careful with it, and we've got some videos on how to take it on or take it off and put it on, because sometimes people will grab one end of it and just kind of yank it off, and if it buckles the material won't tolerate that very long before it will fall apart. I've got a pair that's about 3 years old, still holding up well. Mm-hmm. So if you're careful with it, we expect it to at least last a year. Your audience can also bill this to their insurance. So that's another thing that, in case they're concerned about the cost and don't want to pay for it out of pocket, if their insurance has a durable medical equipment provision, they can bill it to insurance too. But we hope it will last a year. It's got a materials warranty for 90 days. So if somehow it falls apart or breaks or whatever, within 3 months, we'll send a free one out. There's 4 sizes too, and we're adding a 5th size. Most people will fit a medium, even men. Most men will fit a medium. Larger men will fit a large, small women will fit a small. We literally have children, though, as you've probably seen in your practice, with some overlapping toes. Mm-hmm. That's one of our most gratifying testimonials, is we had a 4.5-year-old boy with overlapping toes on both feet. In 18 months, one of his feet was completely cured. And we've got photographs of that, too. So some of our colleagues aren't very happy about me making the claim that we can cure these things because, as you might recall, at least my upbringing in podiatry was that these things are hereditary and that footwear is really not that related. But after learning from Dr. Rossi, I'm not sure that's the case. In fact, I would think that if these things were genetic and not related to footwear, we wouldn't be able to reverse them non-surgically. But yeah, we've got some great photographic evidence. And one of the things that's different about podiatry from maybe internal medicine is if we were studying liver enzymes, we would have to do some surrogate testing. We would have to do double-blinded studies. But when it comes to our feet, it's a visual. You have a bunion or you don't have a bunion. You've got a bunionette or you don't. So we take a picture of every single person that comes in the first day, and we're doing a research project. We're going to show that 90% of my patient population, I'm not sure if they're like yours, but I think they probably are, is wearing shoes that are not shaped like a natural foot and probably are too narrow for their feet. The other reason why we take the picture is we want to show them what their feet look like a year from starting this process. And I've yet to see somebody that doesn't have some changes. I've seen a few people where the changes are very, very slow. They're 2 or 3 years down the road and they've hardly made any gains at all. Mm-hmm. I've also seen young women reverse their bunions in 9 months. Wow. Which, again, if you tell a lot of our colleagues that, they're going to say that I'm selling snake oil or they're going to call me names. But again, I don't think you can argue with a non-photoshopped photograph. A before and after is pretty telling.
Yeah.
So it's really gratifying if the patient can look at their footwear as health equipment as opposed to fashion presentation, if you will.
Yeah. Well, great, Ray. We have about 2 minutes or so. What I'd like you to do is end. I know we talked about bunions, hammer toes, a couple of other overlapping toes. If you could just kind of go through a list of the top 10 things that these are used for, and then explain once again where people can find more information on the web about these.
You bet. I think probably they're most effective for most what you and I would call digital deformities. So the hammer toe, the mallet toe, the claw toe, bunions, Taylor's bunions. I also find it to be tremendously effective for what I think used to be called plantar fasciitis, although some of our colleagues still call it that. Dr. Lamont from Philadelphia, one of my professors in 2003, did a histologic study, showed that there's fasciosis there in most people. A study just came out of the Journal of Foot and Ankle Research last year that showed that when we put our big toe in the position that most footwear holds it in, towards the second toe, 20% of our plantar blood flow gets shut off. So we find people healing from plantar fasciosis in a few weeks, whereas they've been in a chronic cycle of therapy and injections and anti-inflammatories and orthotics. So plantar heel pain is very effective for. It's very effective for pronation. In fact, one of our favorite things to show people, and we've got a video for your audience members, it is on YouTube, it's called Pronation versus Anti-Pronation. And in the video, I position my foot the way most athletic footwear will position it. Heel higher, toes up in the air, widest part the ball. And because flexor hallucis longus can't exert its force on the heel bone, most of us in that configuration will pronate more than what we ordinarily would. Then we take the shoe off, or I should say we put my foot into natural position where I pull my toe back out wider than the ball, and only about 3% of my patient population can pronate beyond neutral when their big toe is in natural alignment. I'm getting ready to go to Seattle for the American Academy of Podiatric Sports Medicine, where there's going to be a lot of orthotic talk. And I'm really excited to share that there's a natural way of mitigating pronation if people are willing to wear the right kind of footwear.
That's awesome. That's awesome. If they want to learn more about you, Ray, and Correct Toes, how do they learn more?
Yeah, probably the website would be the best way, correcttoes.com, or if they want to listen to me going over some of these entities, our videos are usually 3 or 4 minutes long, just touching on the salient features, but I'm all over the web too. Great,
great. Well, I want to thank you. This is Dr. Ray McClanahan. He's the developer of Correct Toes. And if you want to learn more, go to his website and take a look at it. Thank you so much, Ray. Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.